Yeah, so that's the title of my topic, arterial puncture techniques and strategies for complication prevention and management. And as Dr. Su said, I am Alejandro Tavez. I work in a hospital in Madrid, Spain. Let me see. Yeah, so when we talk about what is PCI in 2026, we have to talk about all the techniques that we have and we should use in order to achieve the best result possible for a patient. And that includes a variety of techniques and technologies. That includes contrast minimization, also physiology and intravascular imaging guidance of PCI, but of course, vascular access. That's the point where any procedure in interventional cardiology starts, and that is also capital. So when we talk about the access, there's a clear evolution in the last decades, switching from femoral to radial. We have done that because it has been demonstrated that the radial access carries a low risk of bleeding, and that is also related to improved patient comfort and less painful interventions with shorter hospital stays. We know that from landmark rival and matrix trials. And after the initial evidence years ago from radial access to perform PCI, it has also been demonstrated that it's feasible in high-risk subgroups, either ACS and STEMI complex interventions requiring atherectomy devices. So that's one of the reasons that the feasibility in a lot of subpopulations and the lower risk of acute kidney injury and subsequently the low risk of death that it's carried out by radial access, that has led to consider this as the default access in most procedures. So as an example, in our centers here, we adopted radial access quite early for Spanish standards. This is also for the Europe standards, is a pretty big center. We perform more than 5,000 coronary angiographies a year and around 2,000 PCI per year in a network of 4 labs, 4 hospitals, with 7 labs in total. And if we compare the rate of that adoption of radial access nowadays, it's about 95% in diagnostic angiograms, about 92% in all PCI, and about 90% in primary PCI. And our rate of crossover to femoral access is less than 5%. So that means that we can carry out most procedures, the vastly most procedures, with radial access, and that is something that is it's better for the patients after all. And if we talk about radial access, talking about the sheaths is natural because we need good sheaths with good profile to access much smaller vessels than the femoral. The old generation sheaths were sheaths, the ones that we start working in the radial access, had thicker walls with larger outer diameters, and that meant a high risk of vessel trauma and reduced navigability. That limited the use of radial access in a significant proportion of patients. But as the technology evolved, the new generation sheaths, radial sheaths, appeared. These ones are made of thinner walls with reduced outer diameter, while they maintain the same inner diameter. So that's the way of allowing us to complete more complex procedures that sometimes require up to 7 French, that in the past were almost impossible to do by distal radial access. And now it's feasible, and all of these iterations lead to less vessel trauma and improved navigability that are features that are required for good quality PCI. So one thing that is important is that sometimes we tend to ignore vascular access, but if we want to do high quality PCI, everything starts with the high quality vascular access. And in that sense, having a good sheath with good navigability, good performance is capital. So in order to minimize the risk of complications, the good puncture should be always encouraged. That's the way we do it. We start with local anesthesia. We proceed with the puncture with the microcatheter, and when we have blood flowing back, we just gently introduce the wire. There's a soft tip one. We regularly do a very small skin incision in order to reduce the friction of the sheath going into the artery. That is a process that is super fast, and we carried it that way. We also give vasodilators and 4,000 units of heparin as a default. So it's a very simple, very standardized process that minimizes patient pain and discomfort, and we have our access ready to go. So why is important to do this in a standardized and smooth way? Because with all generation sheaths, with rigid ones, the trauma that we cause to the vessel, it often causes spasm, and spasm is something that all of us that have worked extensively with the radial access, we all know that if we induce a spasm, or if spasm happens, that is something that limits the navigability of our material, and sometimes it may even prevent us of completing our procedure with a transradial access. That's an example of how a spastic artery can look like. And the other thing, that why should we aim for good navigability with the sheets? Because sometimes we deal with very calcified arteries like this one, like this that you can see here. You can see how the calcium is in the arterial wall, and this is quite a frequent scenario. If we cannot get into the vessel, or we cannot get the sheath enough into the vessel, that will impede navigability of material. And when dealing with tortuous arteries or calcified ones, it may also prevent us of fulfilling our procedure with transradial access. So good sheath profile is capital, because these arteries are often challenged, and we can even have some stenosis due to calcified nodules in these arteries. And with the former generation of sheets, these arteries may have impede in some cases to carry out the procedure. And then also complications may happen. We do perform radial access because the rate of complications are lower with femoral access, and the complications that we have from radial access are less likely to produce significant bleeding or significant morbidity, but sometimes they can happen. This is case, for example, that we had years ago with a more rigid sheath that came with a stiffer wire, and we had a perforation of the artery during the procedure that didn't solve with balloon dilatation. So we have this very nasty bleeding here in the forearm, and that was caused because the artery was tortuous, and the manipulation with the rigid sheath and a more stiff wire perforated the vessel, and we have to solve it after extensive bleeding with the implantation of a cover stent in the radial artery. It's something that we should I mean, it's completely off-label, but in some situations we may need it. And as I said, complications in the radial access are less frequent, but still they can happen. We have to be prepared, and mainly we have to prevent them. And mostly the way to prevent them is with a good puncture and a good material, with a smooth transition from dilator to sheath, and good flexibility that reduces the risk of vessel trauma and harm to the artery wall. So among the complications, spasm, that sometimes is not really complications, it's just something that we can feel or the patient can feel and make the procedure more discomfort. It's the most frequent one. Bleeding and perforation are more rare, but still they can happen in cases with the tortuous arteries and with extensive manipulation. And the other ones, the AV fistula, pseudoaneurysm, or infection, are much more rare. AV fistula and pseudoaneurysm are often related to inadequate compression of the puncture site after retrieving all the material. And radial artery occlusion is something that some studies have shown a significant proportion of cases, although in the vast majority of them, we don't really even notice because we still have flow from the caudal artery. So to conclude, bleeding and vascular complications are it's something that is associated with increased mortality and morbidity, and is among one of the most preventable complications in PCI, and one of the maneuvers that we can do is switching from femoral to radial artery. That we have done that in the past 20 years, and the new generation of transradial sheaths allow us to perform 2026 standard best practice PCI in the most in most cases with success. So thank you very much for your attention.